Hi, good afternoon. Shall we start now? Or do you want to wait for some minutes more? Hello, can you all hear and see me? If one of you can speak, please.
I can hear you quite well.
Oh, thank you very much. Thank you very much. So, how many people do you expect in these kind of teachings generally? 3, 5, 7 so far. 9. Okay. Mhm. So I think the time given to me was 2 o'clock. It's 2:02. Do you all want to wait for 2, 3 minutes more?
We can give it 5 minutes to wait for some
Okay.
more people,
Yeah.
then
Okay.
get
Okay. Yeah.
started.
Yeah. Thank you. So we'll wait for till 2:07. Then I'll. Okay, good afternoon. This is now 2:07. I think we're still at 3369. So 7 was right. How do you like to do it? Do you want to put on your cameras or do you prefer cameras off? Anybody? Nobody wants to speak. Okay, that's fine. Uh, how how I want to do is that, when somebody wants to ask a question, they can do it, but at that point of time, it is better if they put on their camera and mic. Otherwise, please, mute your mic. So let me tell you, I'm Dr. Jha. I work in Pilgrim Hospital in Department of Psychiatry as a consultant psychiatrist. I work in general adult psychiatry and have been here since 2009, but in psychiatry since long time, much before many of you were even born. So my remit today is to talk about a bit about schizophrenia, a bit about anxiety and OCD. But before I do that, I would like to have some interaction with you. Can you please one by one actually speak? What level of training are you in? Anybody wants to speak first? How long have you been here? What is your understanding of psychiatry? How much you know about psychiatry? Anybody?
Hi, so I'm one of the IMT ones, and usually teachings are around different levels between IMT ones, twos, and threes.
Okay.
We're medics, so we see the psychiatry patients usually from A&E who
Any good?
who usually need to be admitted under medics until they have
Okay.
further review from you guys or have any other problems while they're in the
Yeah.
psychiatry ward, and they're into their acute medical problems and with hopes of having them back to
Okay.
psychiatry wards. Other things we see is also probably referring patients to you guys for assessments of dementia, types of dementia,
Dementia.
stuff like
Okay.
that.
Okay.
That's
Fine.
basically it. I mean,
Thank you very much. Thank you for the context because. And are you all from ULST or are you from any different trust?
we're all ULHT.
ULST. Okay. Good. 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 So I was going to ask you certain question and you can all answer without any order. I'm going to ask you a bit of quiz here. Do you know any celebrity from entertainment world who has some kind of mental illness anywhere in the world? I will give you a clue. Catherine Zeta Jones is one. Anybody, any other names? No. Any sports celebrity that you know they have suffered or they have come out with openly with mental illness? Like cricketer Ben Stokes, swimmer Mike Phelps.
The actress is
Anybody?
now Demi Lovato, and there is Lady Gaga
Yes,
as
yes,
well.
yes, yes, yes.
She had
That's
issues
correct.
with mental health.
Yeah, and
Yeah,
there's
actually a lot. And there's also footballers as well. I don't remember the name.
footballer. Yes, yeah, yeah,
Lost
yeah,
their careers due to mental health.
yes. There's a very famous Indian film actress Deepika. She has come out with that. She suffers with depression. Any politician that you know of? Any ex-prime ministers that you have heard of suffered with any mental illness? Have you heard of Churchill? He suffered with bipolar illness. Any painters you are aware of who has got some kind of mental illness? No? Van Gogh? Have you heard of Van Gogh? Any author? Anybody? Okay. Okay. Let me see if I can share my few slides with you. Share. Oh, that. This is seminar room 2, Pilgrim. Verify. This camera is on. Showing whose camera is this? Please. Yes. So problem is that this I wanted a very interactive session. And before I do any kind of teaching, I would like to know your understanding of certain terms that is used in psychiatry and that is used to describe an illness, mental illness. So, for example, can somebody give me or tell me what is their understanding of the word hallucinations? Anybody who want to try what hallucinations are?
Hallucinations are impaired perception of one of the five senses. Could be tactile, could
Yeah,
be
good,
sensory, could be visual.
fantastic, fantastic. Uh, Good. So hallucination is a perception without any stimulus. Somebody's mic is on. Can you please switch it off? Thank you. Right. So hallucination is perception without stimulus, isn't it? And depending upon which modality it's coming from, sensory, which sensory modality, it could be auditory, it could be olfactory, tactile, visual, and all sorts. But in psychiatry, most important is auditory hallucination, hearing voices. And the voices that patients tell you could be voices or noises. It doesn't have to be a clear-cut human voice. It can be voice of anything. It can be a dog barking. It can be a loud noise. It can be anything. And if it is voice, you can ask them whether they are talking to him or talking about him or her or talking to them directly. And the content, what are they talking about? And that also gives us a clues about what are we dealing with. Okay. Now, what are obsession? How do you define obsession?
Unexplained following of a certain idea or a mindset that's not
Right.
usual and usually can be harmful, maybe.
Okay, that is good. That is good. So obsession. So I am obsessed about, say, cricket, right? And I would like to talk about cricket matches and all the time. Is that what we understand as a clinical syndrome of obsession is? Or is it something different? The difference is obsessions are repetitive, recurrent, intrusive thoughts, images, views, which you don't want to think. It is against your wishes. And person don't enjoy it. There's a distrust about it. They try to resist it, but the more they kind of resist it, the more anxious they get. So this is your obsession. And if you ask them, are your own thoughts, they will say, yes, they are my own thoughts. The ego is syntonic, means that sufferers accept that, yes, these thoughts are my own thoughts. Nobody is putting them inside me. But I don't want to, I'm not like that. I don't want to see these images. I don't want to think something bad. So that distress, like in my case, I enjoy talking about cricket, but it is not, it is not repetitive. It is not intrusive. I bring it on myself. Can you see the difference? What are compulsions? How do you define compulsion?
Are we thinking compulsion like impulsive?
Yes, yeah.
What type of compulsion?
So, doctor, what's your name?
My name is Maram.
Madam. Okay. Madam, apart from Madam, is there anybody else? I mean, Madam is very bright. I can see that she's answering all my questions. Anybody else wants to try this? I can see a few names there. Uh, Jimal, Dwara, Natarajan, Niharika Kishore, Maram Rabbi, just talking. Anybody? Tansi, Raja, Amelia, anybody else wants to have try what compulsions are? Nobody wants to try? Okay, okay, that's
I'm
fine.
afraid a lot of these people are not really are perhaps working or doing something else on the background. So it's sometimes hard, but they do listen.
Right. So I mean, this is the whole problem because this kind of thing is very interactive. Otherwise, um, I thought perhaps we can do face to face better than this. Anyway, so okay, I'll just do my bit then. Compulsions are the motor acts. They are repetitive, stereotyped actions which people do to ward off certain thoughts in their mind that okay, if they touch certain things 3 times, they dress under 7 times. I had a patient who has to comb her hair from front to back 365 times. 1, 2, 3, 5. So you can just imagine that she was going to drop her child at 9, so she started getting ready at 6 o'clock. 1, 2, 3, 5, 7, 8, 9, 10, 25, and she missed one number, then she has to start again. So it can be very, very distressing act. They have to touch things in certain numbers, certain orders. If they don't do, they will get very, very distressed. Okay, so that is compulsion. Now, what are phobias? What are phobias? Whatever you try,
I
you
think
know.
there could potentially be unexplained fear or excessive emotions connected to a topic, subject, or stimulus.
Yeah, that's correct. So anxiety is related to a specific situation. Do you have any example of phobias?
Arachnophobia, fear of spiders. I have
Oh,
that.
yes, yes,
Uh,
yes, yes, yeah. Very,
uh,
very good. And any very common thing that you see in A&E all the time?
and
Agoraphobia,
what? Sorry, what phobia?
agoraphobia, fear of open spaces,
Yeah,
crowded places. They
yes,
don't
that's
want to go to supermarket. Fear of that. I don't, if I,
claustrophobia. People can't get into scanners because of claustrophobia.
yes, yeah,
We
yeah,
do get, yeah,
yeah, yeah. Thanatophobia, fear of death. There are hundreds of thousands of phobia that you can have.
yes,
Yeah.
yeah.
As compared to phobia, So the phobia is specific, isn't it?
Yes.
And what of panic attacks then? Because they are also anxiety. So this is anxiety with a certain situation. What is panic?
Um, Potentially an unexplained, exaggerated body reaction to a known previous stimulus that is unexplained.
Or
The person,
or or you can say that they're episodic anxiety attack,
yeah,
very episodic, and it can happen in any situation. They don't have to have a certain kind of phobic environment where they have to have. It can happen in their home, in the market, anywhere. So panic attack can happen anywhere, isn't it?
yes, that's true. Yeah.
They're episodic anxiety attacks. Just the simple terms.
Okay.
What are anxieties? Generalized anxiety then. So we have talked about anxiety in a certain situation, anxiety which can be episodic, but if the anxiety is pan situational, whenever they go, they're anxious, they're always worrying, they're apprehensive, the common butterflies in the stomach all the time, worrying about nothing, walking on eggshells. That is generalized anxiety, isn't it? Fear, apprehension, what if questions, what if it happens, what if they don't open the door, they don't open the mail, they don't answer the phone call, they get startled very quickly to very loud. If you watch a very famous British comedy, where they said computer says no, they have a certain characters with that, and then there's another lady characters. Oh, forget about the name. She has portrayed this startled reaction, anxiety very well. So there are situations, so anxiety, pan situational, panic, not any specific place, but it is episodic, phobia, specific to a certain situation, right? Um, what is the next slide? Let me see. Okay. What are delusions? What are delusions? We have
Del-
talked about hallucination. What are delusions?
Delusions are ideas that are deeply perceived in a patient's mind on a specific topic. There can be different types of delusions. There can be persecutory delusions. There could be
Yeah.
perception
So,
delusions.
yeah, so you're completely right. So
Yes.
you're on the very right track. So just add a few words to it. For example, if I tell you that, okay, I believe that I'm King of England, right? And my friend, oh, yeah. My friends tell me, yes, you're King of England. Will that is proper? My friend, family, my whole community that I come from, they all believe that I'm King of England. Will that be a delusion then?
If the rest of the world believes it is potentially true and they are not deemed mentally ill, then it's potentially true and it's not delusion.
Okay.
But if it is one
So, one just add one word to your sentence. A false belief,
false belief, yeah.
yeah, held contrary to the evidence,
Okay. Okay.
right? So what I'm doing, if I'm King of England, what I'm doing teaching you here, like you can just see. So what is the evidence here, right?
Mm-hmm.
I'm held contrary to the belief and not
Evidence.
shared by socio-cultural group, right? For
Mm-hmm.
example, for example, we and this IMT teaching means that everybody here has come from outside England, isn't it? Yeah. So if face
Okay.
to face, I would have asked you all, where are you from? Then we can have some cultural context to these things. So, for example, I come from originally from India. Okay. I do believe that my teachers or my late father guide me and talk to me, right? That is my cultural belief.
Okay.
Yeah. Now, contrast this to somebody who is in front of you from local population who's saying to you that I hear my father's voice all the time, right?
Mm-hmm. Okay.
Yeah, and they're guiding me, they're telling me all kind of things, they're telling me to kill somebody, do this, do that, right? I feel that I don't have the right to live. I want to kill myself. I want to kill everybody, all those kind of related topics. I'm telling you that I don't feel that I am hallucinating. Why I'm telling that that person is hallucinating then?
I think the second option would be hallucinating. But the first option is all right because you do have a perception of good people around you and you've learned something from them, so you can potentially call
Yeah,
that guidance rather than
and
hallucination illusions.
it's a cultural context is there because people do believe that, yeah, your parents, your teachers, your your late parents do guide you. They kind of, they are kind of looking at you at a very benevolent level.
That's true. That's true.
Yeah.
Yes. Yes.
Here, you're saying that they're talking to them in a very different way,
Mm-hmm.
goading them to do something bad. The cultural context was lost. Nobody else believes in these things. That is what I'm saying to you. That false beliefs held contrary to the evidence, and they're unshakable belief, false, unshakable beliefs. Whatever the evidence you give, they will not accept it. And it is not shared by the socio-cultural group they come from. Right? So this is sometimes very important to understand that in A&E, you are there, there's a patient who is saying, oh my God, police is looking after me. People are listening to my post, to my, they're scanning my email, they are following me on the phone. It could be sometimes true because I had a patient who was telling me, okay, like I'll tell you what, I'll give you a good example. Sometimes when you do not understand what somebody is talking about, the more ununderstandable something is, it is more of a psychotic thing, isn't it? More gibberish it sounds to you, it is definitely looking like more psychotic. Okay. You said something about being paranoid, isn't it? That people are looking, it can be different things like paranoid, people are after me. It could be delusion of grandiosity that I have got a lot of, cash and all that, isn't it?
Yes, that's true. Yes.
That's true. So a few years back, I saw a patient in a police cell. He was saying, who was that famous Scottish actor? Sean Connery? Yes, Sean Connery, yes. He is his gardener, and he was arrested on suspicion of being very agitated, drunken, and saying all kind of loud, grandiose things. And he was arrested in Boston. So, well, what is he doing here? Sean Connery. Okay, fine. Oh, yeah, yeah, I have seen all those. He was dropping names. Oh, I have seen, who was that um, actress, Haley Berry. She has come to visit for party, and he was just dropping names that, oh, you have seen them all. They have come for a party. They tipped me £1,000 this and I said, okay. The more he said, okay, okay, fine. He's quite manic. And after 1 or 2 days, he gave us a phone number to call, and it all turned out to be true. He was actually working in one of his farms in Scotland.
Oh.
Sometimes what happens is because we don't see it as being possible, isn't
Mm.
it? So he was actually working in as a staff, and he has actually photographed of his phone of all those actors. They were coming on private helicopter jets, and he was his staff, so he was in a very close contact with all of them. He could see them, and then you had, oh my God. So sometimes people assume that in a context that, oh, it can't be true. So before you say something, have a kind of pause. Okay, maybe he's saying it could be true, but okay, let's find something. So If it is evidence is not there, then only you can say, isn't it? So this is sometimes is a common mistake. Sometimes you say that I had a patient here who was saying that my I'm under police radar. Of course, he was involved in anti and in a protest in Boston, and yes, he was shown us the people he was actually being investigated for certain crimes. Again, proof that yes, it was true. Not all the time, simply because he's coming as a mental outpatient, we have to see that he has got a mental illness, isn't it? I had a patient only the other way. Do you know in Boston where Asda is? Are you from Boston? Anybody? So there was this lady who was saying that the cameras are looking at my bedroom all the time. I feel so paranoid because people are looking at me. I said, okay. And do you feel that, yeah, all the time camera looking at me all the time at all angles? And then a nurse reported that yes, it is true because her bedroom is opposite the police camera. So sometimes what people are saying simply because if you assume too many things, well, you can get it wrong. So evidence is very important, isn't it? Just don't assume because somebody is saying something that is evidently wrong. So delusions, obsession, we have got anxiety, panic, anything. So far, any questions? Anybody?
What do you think? How do you think we can manage an acute psychotic episode when they come to us as medics in A&E?
No, no, no. Okay. I'll just coming to that one in a minute. Yeah. So I was told to talk about a bit about schizophrenia and psychosis. So now what I have told you so far, so symptom wise, how will you say you just said psychotic patient, right? What does psychosis mean then? What is psychosis?
Psychosis is hallucinations and delusion.
And what else? If somebody's catatonia, can they be psychotic?
Yes, yes.
Somebody very, very aggressive, angry, very, you can't understand them. They're shouting, they're speaking in a very language that you ask them, how are you? And they're saying something very jumbled of words. Can they be psychotic?
Yes, yes, they could be potentially, yeah.
For disciple. So you have understand how to differentiate, how to have symptomology, isn't it? Symptoms
Yeah.
are there.
Mm-hmm.
Now that patient is there. So what are the differential diagnoses? What could cause these things? What are the so we have talked about symptoms. Question is, what is differential diagnosis? What are you talking about here?
Drug overdose. Schizophrenia undiagnosed.
Yes, yes, somebody who is known schizophrenia, yes.
Known or undiagnosed, yeah, potentially.
Okay.
Um,
What do you know about schizophrenia?
what do you know what schizophrenia?
Yeah,
It's a mental health illness that causes psychosis and psychotic
yeah, yes, good.
that
What are
require
the symptoms? What are the symptoms of schizophrenia?
hallucinations and delusions.
What else?
High and unexplained emotions. We could
Mhm.
have what's it called? There's paranoid schizophrenia. There's affective or
So you,
depression.
so
Schizophrenia.
you can just see. I have put on the slide
Yeah,
positive symptoms, negative symptoms, cognitive symptom, aggressive symptoms, and anxiety and depression, isn't it? So what are the positive symptoms of schizophrenia?
mania.
Mm,
Oh,
positive
sorry.
symptoms are generally taken as delusion and hallucinations. Okay.
Yep.
What are negative symptoms? Put it. Apathy, somebody is not talking to you too much. They're positive speech, they're socially withdrawn, they're looking kind of forlorn, sad, but they are not talking to you. Catatonic symptoms can be, I told you, stupor, mutism, n- negative, whatever you're telling me, you put them in your hand to shake their hand, they will they will whatever you were telling them that we're doing totally opposite to that. Cognitive deficit, there is impaired attention, working memory will be kind of impaired. So these are kind of classical signs and symptoms of schizophrenia as such. And delusions are different things. Sometimes some people will say to you very clearly that I feel that people are watching me in my home. I'm being monitored. My thoughts are being recorded. Whatever I'm telling you, you already know. And there are different words for it: thought echo, thought broadcast, and all that. I'm not going to go into detail of that because that is not useful for you at this point. So here in A&E, you have got a patient who is known schizophrenic. His family members or nurses have brought him. Why do you think they will bring him to the clinic, to the A&E? What are the things that he will say to you that will cause him to attend an A&E?
He's thinking about harming himself or harming someone close to him.
Yes, good. What else?
Probably social pressures as well. A lot of families are more inclined to bring someone to a mental health facility if they have a gathering or someone is around and they feel like he's just not really normal and he's not complying with his medications.
Yeah, compliance. Yeah. So these days, if somebody is in the community, you can bet that they have been treated, they have been prescribed something. They are not taking something that is different. But generally, community patients who are diagnosed will have some kind of prescription with them. Whether they are taking it or not, that we don't know. GPs will not know. Doctors will not know. I've seen somebody in outpatient just now. I prescribed something. Whether he's taking it or not, I don't know. We have no control over that, right? So, but because they are not taking it, as you rightly said, he will be under. He will have. He will be showing signs of relapse, like increase in delusional thought, voices, not sleeping well, going all up, about all the time, talking about killing people, people coming to kill him, and any number of symptoms that you can think of can happen, right? So that is a patient who is known to have schizophrenia, have been under mental health unit, or have been diagnosed somewhere, not taking medication and has relapsed. That is one kind. Second is that there's a patient to you who is young, 29, 20-year-old young boy who is saying that he believes that everybody is after him. Whatever he feels, people are looking at him, talking, but they all know about what his mind does. He's feeling very anxious. He can't sleep. So that is the two difference. He has not been diagnosed yet, right? And the third is somebody who is known to take drugs, have come with a frank symptom which is suggestive of schizophrenia or psychosis, but there's also a frank history of drugs. Fourth group, you are in A&E and a patient comes, you don't know anything about him, nobody is there, police have brought him here, he's behaving in a very bizarre fashion. He's not smelling of alcohol, but there's suspicion that he might be taking drugs. So there are different scenarios now, isn't it? So how do you deal with the first patient who is known to have schizophrenia? What will you do in A&E?
Get the police to try to come and physically restrict them if they're physically aggressive.
No, if they're not, then what?
If they're not, we try to assess them and try to keep them stable, rule out acute any other medical conditions.
Yes,
They
correct.
don't have an infection, they're not dehydrated.
Yes, correct. What
Um,
else?
if they have any other systematic, they usually come swallowing foreign materials like knives and
No, no, but not schizophrenia. No, schizophrenia will not come with that.
okay.
I'm talking about a psychotic patient, 42-year-old. He's known to have schizophrenia, but he has stopped taking the medication. Family members saying that he's talking about voices being too much. They want to kill him. He's very much afraid. He's not sleeping. He's shouting all the time. What will he do? He's not willing to take his medication.
Detain him and section him in hospital if
But
he's
but but
in the
but
best.
sectioning is very difficult things these days. Sectioning, for sectioning, you need a lot of people, amps and all. You can offer him certain medication. You can offer him what you're taking. They will generally give you good history. Taking drugs, alcohol, they will say, no, I don't just want to have, I, I, I have prescribed this medication. Ask him why they have not taken the medication. What will the usual reply will be? Why somebody does not take their prescribed medication?
Mm-hmm. Mm-hmm.
Our side effects.
Probably side effects. Yeah, they don't like the side effects, or they don't have a location. Some of them we get are homeless, so their things are stolen from them. I had
Yeah,
that once.
but again, but those are rare examples. Common, what you see is that somebody lives in a
They don't
flat
want
or
to.
yeah,
Yeah, they don't want to take it because they don't think they're ill.
they're ill. So there's a lack of insight. Yeah. Then the question of what you asked earlier was, are they suicidal? So you have to do a bit of risk assessment there. So mentally ill patient, known diagnosis of schizophrenia, not taking medication, thinking that he is going to kill himself or he is being going to be killed. He has tablets at home. What do you do there? So what do you do practically there in those cases? Either you call crisis team or call the liaison services, isn't it?
Yes.
Yeah.
Yes.
What do? Then they will either offer them home treatment or admit them, depending upon whether they have bed or not, or whether somebody there at home. If he is very suicidal, he can't be sent home. Of course, he has to be kept safe. Then they get admitted either voluntarily or involuntarily under section, isn't it? I'm not going to talk about sectioning. That's a very big topic in itself. So that is one kind of outcome. You are left with most of the time what I have seen in A&E is you have got a patient who is very much aggressive and there is nobody to give any history. Police has just caught him. He was shouting in the high street. You have no history on him. He does not know who GP is. What will you do with him? Will you give him something to calm him down?
If he's shouting and aggressive and possessing danger to staff, then yes.
Yes. What do you prescribe?
It depends on the age and his background. If there's no background, there's no Parkinson's, any other problems,
Yes.
is a good thing to start with. Usually, just to calm them down for a good short time until
What
you
will you, sorry, what will you give him? When you
midazolam.
die? Ah, midazolam. Why midazolam?
If he's aggressive, then yes, midazolam sometimes, or
Have you given the midazolam on the A&E?
um or lorazepam, really, whichever.
Lorazepam, yes, yes. So lorazepam is much more common.
Mm-hmm.
Yeah. What is the difference between different benzodiazepines? Body wise,
Action.
yeah. So it is duration of action, isn't it?
Yeah.
Some benzodiazepines take longer time to act, some takes less time to act, but in the body they all kind of convert it into the same thing, isn't it? So lorazepam is a short-acting, good medication. They can calm somebody down quickly within half an hour. They are good hepatic profile. They bypass the hepatic metabolism. So it is good thing to try, calm down, and then you can take your history, and then from there, try to kind of dispose the patient in the right direction. Sometime what will happen is that you have a patient, you don't know he's taking a lot of drugs, but he's very agitated. What will happen then? He's in A&E now. What will you do? He's shouting, he's aggressive, he's throwing the chairs around. You are in A&E. Will you call police to help you out?
Yes, definitely.
Yes. So be safe, make yourself safe, make patients safe, make other patients also safe. Like safety is the paramount. Do no harm. First of all, try not to approach him if you feel that he is aggressive, on your own. Talk to police, and then if somebody has taken 2 grams of amphetamine, right? What will you do? Will you start to calm him down straight away, or would you like to let some time pass and then you can give him some medication? do something. Similarly with alcohol, he's somebody come with reeking of alcohol. What will you do? 49-year-old patient, I was telling you from yesterday, he went to A&E, completely had drank a bottle of alcohol, not a drink of kind of spirits, very unsteady on gait. He was on known antipsychotic medication, had not taken it for 3 days because voices were telling him not to take it, drank alcohol as a self-medication, got very much shouting. Police brought him to A&E. Here is a patient reeking of alcohol. You can't talk to him much. Can you do an assessment there?
Probably assess for other toxicities if it's safe, and start
But
the
but
alcohol
you
toxicity
have
one.
to give him time, isn't it? Yeah, you can't talk to him much because he's not in his senses at that point of time. He's too drunk to give you any coherent answers.
Call family,
Family, you don't know the family there or not. Police has just they have no idea about him. They're trying to find out.
check his pockets, maybe papers, anything,
Yeah, but what I'm saying is that if you don't have
anything.
anything, he's just there as a person, and you can't give him diazepam because you don't know whether or any benzodiazepine. The best thing is if he's come some most people with like this, if you allow them to sleep in a trolley or somewhere, they will kind of sleep it off. Next morning, they will tell you all the story about if he's too agitated, then of course you have to calm them down with benzodiazepines or things like that. What do you do in A&E these days? Do you put haloperidol still with lorazepam or chlorpheniramine on this thing? What do you use these days?
We have the rapid
Yeah,
tranquilizer
your
back.
process, yeah. So what do you do for rapid tranquilization?
Lorazepam and midazolam usually.
And
Haloperidol is usually in the UNHD trust.
yeah,
There- but in other trusts, we actually used to give haloperidol first,
yeah. So
especially
there's
for
also
delirium and other problems as well.
yeah. So haloperidol and lorazepam is kind of universally used in different kind of doses and different first of some people use lorazepam first, then haloperidol, sometime haloperidol first, then lorazepam, sometime both at the same time. When we were training, it was haloperidol and the lorazepam at the same time. It all depends upon your trust protocol at that point of time. Um, do you know who proposed the term or who kind of described the symptom of schizophrenia for the first time?
No ideas.
Kreplin, late 1800s, he called it dementia precox. So really, okay, now go to the slide. Do you know, because you're not in psychiatry, it's difficult for me to kind of, how do you, do you know how, what is the etiopathogenesis of schizophrenia? How does it happen? Or do you want to know about it, or do you want me to skip about it? You're the only person who is speaking
Again,
here. So,
sorry, what is that?
I mean, what I'm saying is that schizophrenia, do you want me to talk to you about treatment of schizophrenia?
Yes, sure. Yes, please.
Yeah, and the, oh, some chat. There's somebody is putting something in the chat. Okay, please speak about negative akathisia. People are putting a lot of chat. Problem is if I'm speaking, I can't look at the chat. Anhedonia, yes. Akathisia, anhedonia. Please speak about it. Okay, that's good. Thank you. So let's talk about schizophrenia. So schizophrenia, how do you, I mean, you said it is a mental disorder. Yes. What kind of mental disorder is it? I will say it is a neurodevelopmental disorder. It is a neurodegenerative disorder, which is actually started very much when children are being, when a fetus is being formed. At that point of time, when this connection in the brain starts to go haywire and you're born with a deficits in dopamine system, in serotonin system, glutamate system, and everything. So neurochemistry is definitely bad there. Natural history of schizophrenia is that before it becomes apparent, there is a pre-morbid state where you can see that some boy or girl is kind of calmer. They're not taking too much interest, but they're not out of ordinary. But yeah, they are kind of concerned to the parents. And suddenly around teenage, late teenage, around A levels or GCSE level, they start to have what is called prodromal symptoms, which include a lot of positive symptoms, especially ideas of reference, which mean that people are talking about me, they are looking at me, people are referring to me in some form. Certain negative symptoms, they become quiet, they try to withdraw themselves, suicidal, and because they become very fearful of with all the experiences, sometimes they want to kill themselves. That is the time when they're having, and if not treated, it goes on to have first episode of schizophrenia, where all any antipsychotic that you know of can be tried and they will be equally good in 60% of the cases. 40% of the cases you try a second type of antipsychotic, 60% of that population starts to get stabilized. And after 2 3 trial of antipsychotics, you get a patient who is totally refractive. So that is the kind of normal course of schizophrenia. It never goes away. There is a lot of genetic loading, and this has come up. There's no single genes that have been found out to be etiologically important or significant, but they are small gene effects. So there are hundreds of genes of small significance. They all add up to make. So this is polygenetic effect. And the twin studies have shown that in identical twins where genetic material is almost same, they're 8 times higher than both the children will be schizophrenic if even if they are reared apart. So if you have got same children at the same kind of places, you can understand that the effect of the environment on them. But if they are reared separately and still have the same illness, then you can understand the how genetic influence is there. First degree relative of these parents also have a significant mental morbidity. So there is definitely a genetic component to it. Do you know any environmental effect that can affect schizophrenia or the onset of schizophrenia or they can modify the symptoms? Anything, any environmental thing that can cause schizophrenia or can affect symptoms? How about cannabis?
Cannabis does precipitate psychosis, actually. Cannabis
Yeah, yes. And
precipitate
also not everybody gets psychosis with cannabis.
not all
Yes.
ones are genetically approved.
So somebody says cannabis, cigarettes. Okay. Cannabis is definitely one thing. Can
MDMA, all these drugs.
amphetamine, cocaine, definitely they are very much psychogenic.
Yeah.
Heroin not so though. Heroin not. But amphetamine, cocaine, definitely yes. They produce a symptoms totally similar to schizophrenia. So stimulants.
Yep. What did you say? Other environmental,
Yeah, yeah.
like the weather and stuff, or what do you mean?
Yeah, like in anything environment wise. So migration, mother's obstetric history, they can all influence a bit, isn't it? Second,
Mm.
third generation influence of migration. There's a big study going on. Does migration influence psychosis? There are multi-central trials are going. Do you know which racial, there's a race, the impact of race on schizophrenic symptoms? Which kind of ethnic group is most susceptible to schizophrenia?
Is it black African?
Black African, yes.
They had a lot in Sudan. I'm from Sudan.
Yes, yes. Black Africans also in America, the black Americans are more likely to be imprisoned because of
Schizophrenia.
the mental health. So it is also political environment there.
Mm-hmm.
So because there's a racial profiling, and if you have got symptoms taken for granted. So there's a lot of cultural issue, political issue as well. But yes, as a ethnic group, yes, black Africans are most likely to their prevalence is very high. Okay. Sex ratio is about same 1 to 1. Lifetime prevalence about 1%. How many of these schizophrenic patients do you think end up in harming other people? In 1 year, let me ask you a question, simple question. If there's 100 homicide in 1 year, just in England, just 100, they're in thousands. If they're in 100, how many of them would be done by somebody who is suffering with mental illness or schizophrenic or schizophrenia?
20%.
Any other guesses in chat box, please? They're very, very less, not even 1%. So this is a myth. And this myth is sometimes, you were all doctors. There's a lot of myth about mental illness and the common language. If somebody that you don't like, they speak in a different way, you don't like your friend, they have views of you, what do you say? Oh, he or she is a psycho. Films have contributed to it, common press has contributed. So common thing that psycho, she is a madman, mad woman, off the rocker. There are different terms. So there's a lot of stigma to the mental illness too. Things that we don't understand, we say that a project, okay, he's schizophrenic, he's aggressive, he must be doing something to other. They don't. This is fact. So schizophrenia per se is not somebody who's going to go out and kill you. Okay. In fact, not it's hardly mental illnesses which you know they go on to kill themselves more than they kill other people. So there's a lot of stigma to the mental illnesses, which as a doctor, can I ask you all a very open question? Be very honest about it. Very, very honest about it. If somebody comes to A&E in Pilgrim, Boston tonight, and he's saying that they have got heart problem, and because they have got palpitation, and then the same says that, well, I have been seen by the psychiatric outpatient, how many of you will change straight away? Okay, it could be a panic attack straight away.
I would personally think it's a panic attack, but I'll still be indulged to investigate it and have an ECG.
Investigate it, yes, so that is the correct answer, but generally people beliefs and the perception of the patient changes, isn't it? Oh, he might have something to do with. They are not taking as seriously as other people would have been. So it's a good thing that we're saying that.
They're the 40% of frequent attenders in A&E with different problems that are not really structural, and they cause a lot of chaos in A&E. And at
Exactly.
first it is, but when you see the same face 10 times a week, you're less inclined to take that person seriously because they don't see A&E as a place where to
Yeah,
come to when they're ill. It's
yeah.
more
So
they think about it.
thank you for being very honest. That is the truth, isn't it? So it is like calling wolf because you're coming every day with every same problem, they different problems, but you know that generally they have only psychiatric problems. They are just trying to be somewhere safe or somewhere they can talk to people. You know, they're just causing, they don't have any real physical problems. But what if they have?
We
Will
still
you?
investigate them generally if they do present with new symptoms. We are not any less inclined to investigate or treat.
That is what. So that is the correct. Please take them seriously too. They're also, they might be having the problems, but generally perception is that mental health patient when they go to any, they're not taking seriously because when they say that they have got a mental illness, they are believed or accepted less readily than somebody who does not have a mental illness. That is a sad fact. I mean, I am a psychiatrist. I have been doing psychiatrist since many years. I can tell you, even my friends, colleagues who are all consultant psychiatrists, in different department, when we meet socially, there's a joke. Oh, what do you people do? You talk. You don't do. We see 30 patients, you see 6 patients, 7 patients. The perception amongst even medical graduates about psychiatry is very different. So in 2024, in a modern world, mental illness is an illness, and the mentally ill patient also have a body, and they can also they're prone to all the other illnesses that any other person would have. So please, if you see them, take them seriously. Yes, I totally understand your frustration because you have some the same problem again and again every day. It becomes kind of, oh yes, the same patient again. But that is a professional hazard. You might miss something which somebody might regret afterwards. Isn't it? Uh, so coming back to schizophrenia, so here is a person who has now presented in a system as the first episode psychosis. She has got psychotic symptoms. The theory is that in the brain, dopamine and serotonin are not functioning in the way they are supposed to be functioning. How many of you know about dopaminergic system in the body or have forgotten about it now? There are four kind of dopaminergic pathways. Anybody mesocortical, mesolimbic, does this name rings a bell anywhere?
I remember the mesolimbic and the limbic system effects are in somewhere in the hippocampus, I think. That's all I remember.
Yeah, I know
Don't
this is,
probably
yeah. So dopaminic system are in brain, the four kind of dopaminic pathways. One is in the mesolimbic, which the hyperactivity of dopamine in in that. So that controls the positive symptoms and aggression. Mesocortical controls the negative symptom, and there is deficit of dopamine or excess of serotonin, especially in the dorsolateral prefrontal cortex. And then there's nigrostrial, hyperactivity of dopamine, and then tuberoinfundibular, which causes galactoria and prolactin secretion. So just kind of old anatomical things. And it is the treatment is based upon how these dopamine and serotonergic systems are controlled by different kind of antipsychotics. Do you know any name of any antipsychotic that is used these days? First generation, second generation, anyone?
risperidone, haloperidols. But
Correct. What is haloperidol and what is risperidone group wise?
it's the first generation that block
Which
dopamine
Which is first? Which is the first generation one?
Haloperidol.
Haloperidol, yes. So haloperidol, chlorpromazine, trifluopirazine, they were all first generation. When we were students, these were the medication which were available to us. There was no other second generation treatment. How do they act?
They block D receptors, D1 or D2.
D2 receptors, blockers, yes.
Yeah.
But I've just told you there are four kind of states. So in mesolimbic, where there's too much dopaminergic, which is causing you hyperactive, positive symptom, delusion, and hallucinations. So you give any first generation, they will all control that. Patient will have positive symptoms or less. But negative symptoms in mesocortical, where there's already less of this, you give D2, you'll also decrease it there further. So there will be more of negative symptoms there, more of cognitive deficit will be there, isn't it? Through nigrostrial pathway, you increase the dopaminergic thing. There'll be pyramidal symptoms. There will be movement disorders like chorea, tics, athetoid, and something called tardive dyskinesia, which is late onset of the extrapyramidal symptoms. Prolactin comes as galactoria. So then that means that these medication what we were using were only useful for positive symptom, isn't it? Because they were using only on the D2 receptors. And then there were a lot of other symptoms, for example, weight gain or dry mouth, constipation, blurring of vision, postural hypotension. They were all common with the first generation because these antipsychotics were not only acting on the D2 receptors, but they were also acting on histaminergic and muscarinic receptors. So then there was this thinking about, well, we have to have something where we can control the both dopamine and serotonergic, concentration better in a way to have less side effect and more symptom control. And that is how second generation antipsychotic came. So the difference between second generation and first generation is second generation antipsychotics do not necessarily work through D2 receptor blockage, and they theoretically they don't have extrapyramidal symptoms in the normal therapeutic dose. Okay. So olanzapine, risperidone, quetiapine, the commonly used things, they're all are working through mostly through 5-HT1. This is serotonergic and a bit of dopaminergic pathways acting in synergy. Serotonin and dopamine have got a negative inverse relationship. So in mesolimbic, when the dopamine goes down, serotonin is up, which also helps in symptoms, and in other areas too, in everywhere. That is how it works. Okay. Have you heard of something called aripiprazole? Medication called aripiprazole?
Yes, we've seen that prescribed multiple times for our patient.
Yes. Yeah. So aripiprazole is a third generation kind of, or late second generation or third generation antipsychotic, which has got a partial agonist effect on D2. So basically what it means is wherever dopamine is less, it will increase the level, and wherever it is high, it will decrease the level. So that is ideal, isn't it? So it will not cause you much of the metabolic syndromes which you see with second generation one because of the weight gain and cardiac and work on leptin, ghrelin, and cholesterol and glucose and what have you. Aripiprazole in third generation, it is the least likely to cause any metabolic syndrome. So it is being used in more and more fashion these days. And then there is a very specific drug called clozapine. Have you heard of that? Clozapine?
Yes, we've seen it and have it prescribed.
Clozapine is the only drug in England which is, or perhaps in the Western world, which is licensed for refractory schizophrenia. What does refractory condition means? When you try two antipsychotics at the maximum dose for 6 weeks each, symptoms still persist, then we say, okay, they are refractory. And in refractory, if you try clozapine, there's definitely symptom reduction, but it is a dirty molecule. It flirts with different chemicals. Anyone wants to hazard a guess upon the side effect, which is very infamous side effects, which you see sometimes in medical emergency in A&E?
Is it the one that causes agranulocytosis?
Agranulocytosis, yes, but you will not see it very often because by rule we have to do every week for first 16 weeks. If somebody started on the clozapine, we monitor them weekly through clozapine clinics, their full blood count. So that is seen. That is by law, we have to do that. Second thing is after 16 week, every fortnight for next 16 weeks, okay? And then every month. So full blood count is being very intensively monitored. If there's anything we have to, if it so, and the results are set into green, amber, and red. If it is red, we have to stop it, full stop. If it is amber, we have to repeat the blood test in 3 days and again see the dose titration and all that. Sometimes after the red results, we have to stop and re-challenge the patient again. The word is called re-challenge. You have to restart the medication and very cautiously increase the dose further. What is the other side effects of clozapine?
Someone in the comments said myocarditis. I have no idea.
Constipation. Sometimes it can be very severe. Weight gain. One of my patients told me she was size 12 and within 1 year she was size 22, but she was mentally so stable. She said, begged me, please don't take me off. But because of the metabolic side effect and the effect on it was having, the weight was having on her cardiac system, we have to change it. And she was very unhappy with it. So weight gain is very common. Sedation, drowsiness, drooling because of the muscarinic effect, postural hypotension, cardiac, your QT prolongation, arrhythmia. They're very common with quetiapine. But blood changes, agranulocytosis is very important. Sleep, sedation, weight gain are very important thing. That is why somebody on clozapine, they are monitored very closely. Um, you're all medics here. How often do you think psychiatrists do ECG?
Every week?
No, but not every week, but we do more ECG than people give us credit for, because almost all antipsychotic have propensity to affect the QTC interval. And if you do not know the baseline, so we do a lot of QTC these days, the ECG, just to see they have a baseline. What are the other things that monitoring is done for antipsychotics?
I think we just mentioned FBCs for
FBC, metabolic, so glucose, lipids, yeah, kidney function, liver function, they're all very important. They all get deranged with antipsychotic, especially if you have olanzapine, quetiapine, all will have effect on the blood sugar levels. The blood sugar gets deranged, appetite increases, weight increases, insulin, resistance. So you get typical metabolic syndromes, with syndrome X, with all the obesity, truncal obesity, hypertension, high HB1C, high cholesterol, everything, sleep apnea, and you see a lot of them. So we do monitor them very frequently. The side effect of the first generation, I told you the movement disorder are not generally seen with the second generation one. But what we are seeing with the second generation one is more of a metabolic side effects. That is where the role of aripiprazole have stepped in. It is better, but the effect is slower than any olanzapine. So we still tend to use a lot of olanzapine, even though it causes a lot of weight gain and sedation. But patients are much more effectively controlled on this. These medications come both in oral form and in injectable form, especially aripiprazole and risperidone have got injectable preparation. Olanzapine has also has come up as an injectable form. Quetiapine has not yet been produced in injectable form. Clozapine is only oral. So this is some of the things. Apart from the uh, support for antipsychotics monitoring and all that, what other thing do you feel a schizophrenia patient will need for him to be fully supported or fully functional, productive?
Therapy, cognitive behavioral.
For what? Yeah, but any kind of liver enzyme daily inpatient here, liver enzyme lipid, somebody has a Jamal, yes. As inpatient here, you can do inpatient monitoring. Liver enzyme lipids are important every third month, 4 month. It is important to have a, most of the antipsychotic will have effect on the liver enzymes, yes. Sometimes patients who are not happy to take antipsychotics and they can be managed, they're not too aggressive, they're symptomatic, but they're not too dysfunctional. Sometimes in some therapists do what is called uh, they can do offer some psychological therapy in psychosis, but it needs a high degree of training and not they're not very commonly employed. But there are other things, for example, to help them with structured lifestyle, to have activities, even going out, structured routine activities. Those things go in a very long way towards maintaining somebody's or they're integrating back to the society, help with their employment, help with their education, help with their benefits, trying to reduce their cigarette. Because you see, again, the health impact of somebody. Okay, what is the figure for mortality with mental health? Any kind of mental health, more especially with psychosis. What is the figure for mortality figure for mental health and psychosis?
40%.
People with mental health, especially psychosis, die 10 to 15 years earlier than their age match, everything mass control cohort. 15 to 20 years earlier. And the death is not because of any psychotic features, but because of the lifestyle changes, COPD, or kind of it is a sedentary lifestyle, high cardiovascular morbidity, cigarette smoking, their Q scores are very high. That is what their lipids, everything is bad about them. So you have to look at the physical health of the mental health patients. And physical health, do you remember what is the definition of health by WHO is? Health is not only absence of disease or infirmity, but it is a state of positive physical, mental, social, and spiritual health, social health. The physical health, you cannot talk about health without a mental component or physical health component. It goes hand in hand. So in a mental health patient, having a physical health monitoring is very important. because the impact of physical health effect on their medicine will be high. Somebody is on diabetic and you're giving him more and more olanzapine. You have to be careful what to give. Maybe there's a need to change to aripiprazole, which has got less cardiovascular side effect. These are practical consideration for us. Shall we take a 10 minutes break and come back around what time is this now? Hmm. Shall we come back at 3:35? Yeah.
Yes, sure.
Okay, welcome back. So, is there anything on schizophrenia that you would like to know or ask? Okay. I mean, I have not talked to you a lot about schizophrenia because it requires 4 6 hours of teaching on schizophrenia itself. But at your level, I think that's much understanding if you have about schizophrenia that will help you. Um, shall we talk a bit about OCD or any other illnesses that you think you want to know? General anxiety disorder, OCD, anything? Anybody wants to ask anything at this point of time?
Do you have any recommendations for things we need to know when the liaison is out of service, as in the weekends and on night shifts, and we get a bit of challenging
Oh,
patients?
really? Okay. B- so liaison was, do you call crisis team there or you can always try, have you tried calling crisis team?
No, they're not really helpful in hospital. I'm not gonna lie, because they say that they cover things out of hospital. I didn't personally ring them once, but I had one of the nurses tell me that it wasn't very helpful, so I didn't do it. But
Oh,
we were taught about the basic de-escalation, like don't put any knives beside the patient, don't put any tubes,
yeah.
um, give one to one. But it's not really anything very helpful. So if you can maybe teach us something
I,
about
I
de-escalate.
mean, I mean, this is the whole problem because this is escalation. I don't want to talk because this is like service things. I don't want to tell you anything which will ideal world and practically, as you said over the weekend, there was no crisis team or sorry, was no liaison team. Yeah, and you were all not told about that.
Yes.
Yeah, the best thing is you let your consultant know and to talk about it. That what are the lines of escalation at this from what are, if you have a patient, can we ring the SHO in psychiatry directly? Can we bleep them or can we not bleep them? Can we call them through SP single point of access? We have. Do you know about single point of access?
No.
No. So like you are called through the switchboard office switchboard in a ULST. We are not part of you. We are different trust. We are LPFT, Lincolnshire Partnership Foundation Trust. So we are not part of the uh, United Lincolnshire. We are totally different trust. So our switchboard is through single point of access, which if you ask your liaison service or crisis team, they can give you. You can always ring them to see, get any advice to see who are the doctors who can call. You can always ring the consultant that we have got a patient and what should we do because there's no liaison services, no crisis team. Who do we want to call? So through the single point of access, you can always get somebody from psychiatry to talk to you. Uh, I don't know how quickly you can get the answer, but generally you ring. That is our switchboard, not a common switch, but you ring them. They will be somebody will answer, and then they will ring us, and we call you back on your number. That is how it works. But generally, in the hospital, the crisis team and the liaison services are the first port of call. They tend to call the doctor. But again, in a situation like this, I think that is the way forward. Apart from that, I don't think what else can you do at this point of time apart from keeping patients safe. But I can assure you that if you call the consultants, they will definitely call you back. So try next time if it happens. And if they tell you, just you can say that that Dr. Jha told me to, choose this number. Anything else? I mean, if you want, I told them that I can talk about a bit of social anxiety, anxiety disorder, agoraphobia. So if you want to ask any questions about these things, do you need a bit about nice guidelines on or your advice on these conditions?
I mean, the only thing we prescribe really is antidepressants for these patients, and we try to prescribe as per BNF, but
Yeah,
we're
I mean,
very updated. I'm personally not very updated when it comes to mental health
yeah,
disease.
I know this year. I think problem has been that the remit had not been very clear to me as well. It was kind of left for us to decide because if I am not know that what you wanted to know, perhaps next time we can come prepared with kind of what you can do. You can send us a lot of questions beforehand. I don't think this kind of teaching is helpful in this kind of setting because what you need is more of a practical on-hand training, isn't it? Or on-hand advice. Theoretical teaching is a different kind of teaching. This is what you need is more what to do things, isn't it?
I agree, yes.
So maybe this is the kind of problem that has been happened because I was told in April, February, March time that who we can get involved. So okay, I can do something. I said, okay, fine. So I prepared something for schizophrenia, social anxiety, this and that. But I can see from your questioning that yes, you are more looking at practical things which you can do in an emergency. So there's one thing is to routine appointments and routine management, and there's totally other thing to do what to do in the A&E side. When do you have next slot for psychiatry? Do you know when is the next slot for psychiatry is in 5 months or 4 months time? Is any Matthew there or has she left now? Uh,
It's usually arranged by the admins. We don't really know,
and
but we've been
yeah, so I think
through myself.
so Miss Matthews, are you there? And yeah, Matthews, see the one your coordinator. Best thing is if you can tell her what kind of teaching you would like and what are the things that you would like to be covered. Because this has been, I can tell you that A, because it is not face to face, and when you do online teaching, so they are good for slide presentation and talking. But when you want to have interactive, then this kind of teaching becomes a bit of difficult thing to do, especially with so little participation. Uh, I think I'm going to Aganya to say that perhaps next time, if you all can, if you do have a group where you can share questions, or do you have a group where you can ask people what kind of things that they want to know? Can somebody take lead there, please? You have been quite vocal, Mariam. Do you want to take the lead there?
So the thing is, we've got only probably like 5 or 6 weeks left before we
Oh, oh,
rotate. That's just tricky.
right.
It's not going to be linked anymore now. That
No, yeah, this is the problem. I'm sorry because this is kind of thing that I know now. So perhaps next time for the next cohort, if you can tell them to speak to to the coordinator that what are the things that you would like to be covered on the A&E side, more of emergency side, I was told totally different. That it is mental health teaching. That is a different kind of teaching than what you want to know.
It's fine. I think it's really I think it's just my own personal interest, but a lot of the listeners here are really just generally interested in mental health and overall. So
Okay,
it's just really
okay,
first of all, yeah, it's just following
okay.
up
Because I
this.
thought that perhaps we can talk, have an interactive session where people will be asking about different kind of disorder that you have heard or so. Anyway, so yeah, treatment for OCD. We have talked about the symptoms. If you got a patient there, first line of drug is uh, SSRIs, which are like fluoxetine and sertraline and things like that. Not citalopram, because citalopram can have a higher dosage effect on ECG, especially QTC interval. So try not to use citalopram, but fluoxetine, sertraline, yes. If that does not work, at higher doses, more 40 to 60 milligram or 100, 200 milligram of sertraline, try to come back on clomipramine. But for that, because clomipramine is a license indication for OCD, but you have to do a lot of monitoring with ECG and BP and all those things. But again, it's a very good drug, a lot of side effect, but it works. And if they don't work, then you can actually add a bit of antipsychotic as an augmentation, both risperidone, olanzapine, quetiapine, anything. They do work. I found olanzapine and fluoxetine works very well for refractory or difficult cases of OCD. But OCD also works, respond very well to psychotherapy. CBT is very, very well known thing to work with psychotherapy. So sometimes psychotherapy alone for mild to moderate severity can work. Severe cases, only the medication or the combination of medication and psychotherapy works. Have you heard of operations in psychiatry, surgical operations in psychiatry? Do you think psychiatrists will ever perform or refer patient for surgery for psychiatric symptoms? In a country like UK, about 5 or 6 patients in 1 year do get operation for OCD symptom is completely severe, very distressing, and anterior cinguloctomy is used. It's a very different, very difficult process to do, a lot of legal requirements, but it is performed. So that is OCD for you. Anxiety, we have talked about anxiety, generalized anxiety disorder is something which is present in all situations. What will be the treatment? What do you think are the treatment for anxiety disorder? Again, SSRIs are there. Benzodiazepines are not routinely used. There can be only adjunct as a very small dose for very small time. Therapy is the mainstay of the treatment. Both exposure therapy, CBT, different kind of psychotherapy we use are there. At this point of time, I would really encourage you to ask me questions on illnesses. Anybody wants to ask any question? No? In that case, then let's stop it here. And thank you for giving me time. And maybe best of luck for your next training rotation. And sorry if it was not very useful for you all. Thank you.